My dear students, in this video, I am going to discuss about the point of care biomarkers of sepsis and their current implications. Let us start with a case, a 72-year-old woman with a history of CKD stage 4 and ischemic cardiomyopathy with an ejection fraction of 25% and recent abdominal surgery is admitted to the ICU with altered mental status, tachypnea, and hypotension. On examination, her BP is 82 by 50 millimeters of mercury, heart rate is 124, temperature is 38.5 degrees centigrade, and saturation is 90% on room air. She has generalized edema with a low urine output, less than 0.3 mils per kg per hour, and a distended abdomen. The laboratory investigations are delayed due to a malfunctioning central lab analyzer. The treating team suspects sepsis, but differentiating between septic shock and cardiogenic shock exacerbated by surgery and renal dysfunction is challenging. The point of care tests are available and which reveal a lactate of 6.2 millimoles per liter, procalcitonin of 11.5 millimoles per liter, and a CRP value of 150. Now, can these point of care tests aid in the medical management of this patient, considering malfunctioning central lab analyzer leading to delayed delivery of the reports or the routine investigations? Whenever in these patients have to be followed, algorithmic approach can be helpful. In the first approach, we have to gather informations about the clinical impression based upon the presentations. As we can see that this patient has hypotension, tachycardia, tachypnea, fever, and altered sensorium. So this strongly suggests sepsis. But these are not alone. There are certain complicating factors, which include CKD, which predisposes to uremic symptoms, and which also alters the biomarker clearance, particularly for procalcitonin and lactate. Therefore, the reliability of such biomarkers is reduced. The patient also has low ejection fraction cardiomyopathy, so at a risk of cardiogenic shock, making fluid resuscitation very tricky. The patient in question, the lady, also has undergone recent abdominal surgery. So this itself raises suspicion for intra-abdominal sepsis, but it may also be a post-operative inflammatory response, which may mimic intra-abdominal sepsis. So in this patient, the dilemma is of whether this patient is having septic shock or cardiogenic shock or a mixed shock with elements of both present together. This is the situation where point of care biomarker helps in the diagnosis. Let us see the values individually. A 6.2 millimoles per liter of lactate indicates significant tissue hypoperfusion. And not only that, it is strongly associated with poor prognosis. However, high lactate alone cannot differentiate septic shock from cardiogenic shock. So we look into the procalcitonin, which also we see is markedly elevated at 11.8. Now, this procalcitonin is more specific for bacterial infection, and it helps distinguish infectious etiology from non-infectious inflammatory or cardiogenic causes. So its elevation in this patient supports diagnosis of septic shock as the primary driver. Next, we find that in this patient, the CRP values are 150, which means the CRP is elevated. Now, elevation of CRP confirms inflammation, but it is non-specific. And it adds little beyond procalcitonin in acute decision-making. Bedside ultrasound as a procedure, it is a point of care procedure, identifies intra-abdominal collection. which suggests probable anastomotic leak. So after the first step, in the second step, we are able to reach the diagnosis with more certainty when we carefully scan and screen the individual values of the point of care tests. So the constellation of findings, that is fever plus elevated procalcitonin plus intra-abdominal source plus hyperlactatemia, confirms septic shock with cardiogenic dysfunction as a complicating comorbidity rather than the primary etiology. In the next step, we have to look into this biomarkers, the point of care biomarkers, from a different angle, and that angle is pertaining to risk stratification. So lactate of more than 4 millimoles per liter categorizes this lady as a high risk, which is consistent with the sepsis 3.0 criteria for septic shock. Persistent lactate elevation, again, despite resuscitation, would also predict higher mortality. And procalcitonin kinetics, that is, whether procalcitonin is falling or persistent elevation, they can help anticipate antibiotic non-responsiveness as well as prognosis. Next step, the step 4. Now we have to evaluate this point of care biomarkers for guiding therapy. So in this patient, antibiotics based upon these biomarkers require immediate initiation justified by elevated PCT, which supports bacterial infection. Fluids, the raised lactate says that lactate clearance should be used as a resuscitation target, but this should be carefully balanced due to cardiomyopathy and low ejection fraction. And the need to start vasopressors should be early initiation given the refractory hypotension despite fluids, because too much of fluids can again produce problem. And of course, source control based on the point of care abdominal ultrasound. There is evidence of intra-abdominal collection, so source control needs to be undertaken. Therefore, in this step also we see that the point of care biomarkers allowed faster initiation of targeted therapy without waiting for central lab confirmation. This is not to say that central lab is not required. It is required and it is more accurate. But in times of problems leading because of delay or non-functioning analyzer, the treatment of the patient cannot be delayed. And in such situations, point of care tests are suitable alternatives. And then it is the step 5. After doing everything, when we have to monitor the response, there also the point of care biomarkers have a role. Serial lactate monitoring trending downwards after fluid and vasopressors indicates good resuscitation and can be taken as a marker of the same. Serial procalcitonin failing levels over 48 to 72 hours would support adequacy of antibiotics and adequacy of source control too. The CRP kinetics, although less useful acutely, but their downward trends would support overall improvement. So always it is seen that this, if they can be taken as a wholesome number collectively, the monitoring of response is facilitated. Therefore, if you see in our patient, when we combine all the findings, a point of care lactate of 6.2 confirms severe type tissue hypoperfusion. A point of care PCT of 11.5 suggests bacterial infection rather than pure cardiogenic shock. And a point of care CRP, which is raised but is less discriminatory. The USG shows intra-abdominal collection, which suggests anastomotic leak. So the patient is started immediately on broad-spectrum antibiotics and source control surgery is arranged. Serial point of care lactate shows partial clearance after aggressive resuscitation, thereby after that helping balance fluids with caution because of a cardiac dysfunction. So this case therefore emphasizes that how, if we follow this 5-point or 5-step algorithmic approach with the biomarkers like lactate, procalcitonin, and CRP, they can clarify the diagnosis and can guide management in a complex high-risk patient where multiple overlapping pathologies can make clinical decision making very difficult. If we look into the various biomarkers, the ones in order of their importance and availability, the lactate, we can see that it is a on pathophysiological basis, it is a marker of tissue hypoperfusion and anaerobic metabolism. The turnaround time is 1 to 2 minutes with the aid of handheld analyzers. The clinical utility is that it can detect occult shock, it can guide prognosis, including mortality and severity, and also guides resuscitation based on lactate clearance. But it has got its own limitations, like it is non-specific. It can be elevated in seizures, liver failure, use of beta agonists like salbutamol, etc. Next, we look into procalcitonin. Again, the physiological basis is known to us that it's a prohormone of calcitonin and is induced by bacterial endotoxins and cytokines. The point of care immunoassays have a rapid, fast turnover time of 15 to 20 minutes, can differentiate bacterial versus viral and severe inflammation, but antibiotic stewardship prognostic marker is or a decline is suggestive. But this can also be false positive in patients with trauma, burns, renal dysfunction, and also the values of PCT may not rise in early or in localized infections. The C-reactive protein is a poor man's biomarker. The finger prick lateral flow tests take an average of 5 minutes, and their clinical utility lies in early infection screening, because serial monitoring for treatment response. And the good thing about CRP is that it is widely available, but it is low cost. Its specificity is low in certain cases, but it is elevated in autoimmune disease, trauma, and malignancy. The kinetics become slower and it peaks in 48 hours. Then there are some new markers too. The S-TREMI1, which is released from activated neutrophils and monocytes in bacterial and fungal infections. Very rapid immunoassays in less than 30 minutes, can differentiate infectious versus non-infectious SARS, and is useful in pneumonia and peritonitis. But this also suffers nearly the same limitations like availability needs, multicentric validation, etc. Likewise, pre-sepsin or soluble CD14-ST. So this is released by monocytes macrophages during phagocytosis of the bacteria. The point of care assays emerging takes less than 20 minutes. Early rise in bacterial sepsis correlates with severity and outcome. But this is also has limitations, like it is mostly a product of research and is costlier in the market. The MR-ProADM, this is one biomarker which is showing a lot of promises. It is a surrogate for adrenomedulin, which is a vasodilatory peptide linked with endothelial dysfunction. The advanced POC and biosensors in trials are available, and it can be used as a prognostic marker which can predict organ failure and mortality. But again, the problem is that it is not widely available and it needs validation. Cytokines IL-6 and IL-8, they are also can differentiate early detection and may stratify sepsis based on phenotypes. But the limitation is that there has been no standardized routine as such for clinical use. So that way it may take some time. In addition to that, there are some new biomarkers that require more evaluation. One of them is pancreatic stone protein, which is a new damage-associated molecular pattern, DAMP, that can be measured quickly and shows potential for detecting sepsis 3 to 5 days before the symptoms appear. So in these patients, even before the symptoms actually manifest, they can be diagnosed, especially when they are combined with CRP. Monocyte distribution width, it is again a parameter derived from the standards common complete blood count, and it is suggested as a diagnostic tool because monocytes enlarge during bacterial or fungal infections. Then comes the neutrophilic CD64, which is a marker on antigen presenting cells that increases in response to infections and endotoxin exposure, and it also indicates a state of infection. Now moving on to the second case, a 62-year-old male diabetic with stage 3 CKD is admitted with fever, confusion, and hypotension. On arrival, his blood pressure is 78/46, heart rate is 152, respiratory rate is 28, saturation is oxygen is 90% by mask. Suspected source is urinary tract infection because there is history of dysuria along with positive urine dipsticks. The initial 30 minutes, the labs show lactate of 5.2 millimoles per liter. WHO is WBC is 13,000. Creatinine is 2.6, which is more reason from the baseline of 1.6. The bedside POC biomarker availability are lactate, procalcitonin, C-reactive protein, presepsin, and GAN. So what are the diagnostic and decision challenges? If the POC lactate, it is elevated because the value is 5.2, suggests tissue hypoperfusion and guides immediate resuscitation. But the challenge is that it is not specific for infection. It can also be elevated in seizures, hypovolemia, mesenteric ischemia, etc. Next comes to the point of care procalcitonin. The result shows a value of 0.52, which is borderline. In CKD, interpretation is difficult because baseline PCT can be falsely elevated. So there has to be some debate between the treating teams and the primary team that should antibiotics be escalated immediately or it should be waited for cultures to come. So there are also diagnostic and decision-making challenges. The point of care CRP elevated at 110 in this patient, non-specific, rises slowly compared with PCT and provides poor temporal guidance in acute phase in sepsis resuscitation. The point of care presepsin is also the result has a value of 1200 picogram per ml and the cutoff is 600. It is claimed to be rise earlier than PCT in bacterial sepsis, but the challenge is again that it is still influenced by renal clearance, and high value can be seen in CKD without infection. The point of care NGAL is becoming available in more and more centers now, which is a specific renal biomarker, which is elevated, but this elevation of up to 180 nanograms per ml with a cutoff of 150 suggests its benefits. It also, the point of care NGAL suggests early AKI rise even before creatinine rises significantly. But the clinical dilemma still remains fluid resuscitation for sepsis, whether the risk of worsening renal injury or resuscitation are contradictory to each other or not. Now, there are certain difficult decision angles too. The first important point is biomarker discordance. What to do when lactate suggests severity, but procalcitonin is borderline and CRP is non-specific? Nobody has the answer. But risk of both overtreatment by unnecessary broad-spectrum antibiotics and undertreatment with delay in the initiation of therapy needs to be looked upon. In resource-limited settings, in many sources, only lactate is available. So does investing in presepsin NGAL point of care really improve outcomes or just increase cost? So this is also a very important consideration, which throws a lot of queries on your mind. The temporal kinetics, the procalcitonin and presepsin may diverge in timing. The PCT is slower to rise, presepsin is faster. So which one or which of the two should be used to guide antibiotic stewardship? And the fourth difficult decision angle is that The AI-based sepsis production models increasingly integrate the point of care biomarker value with the vitals, but should intensivists rely on algorithms when evidence is not yet mature? This is something which is really important to ponder upon. So, what is the final takeaway message from this lecture? With lactate, it is rapidly available, strong prognostic marker of hypoperfusion. The limitations that it is non-specific, it can be raised in seizures, ischemia, and it does not indicate infection directly. In addition to that, if you see into the lactate, there is a case-specific role. If it is very high, as it was 5.2 millimoles per liter, that triggered early resuscitation and best used as severity and resuscitation marker, not diagnostic of infection. The procalcitonin is useful for bacterial infection and antibiotic stewardship. The limitations are the borderline values are hard to interpret and elevated in presence of chronic kidney disease, trauma, and surgery. The case-specific role that at a value of 0.52, so it has a confounded interpretation. And the take-home message would be that helpful if markedly high or falling with treatment, but gray zone values are sometimes misleading. Again, if you look into CRP, we know that CRP is widely available and it is cheap, and patients with CRP, the impression is that since it is a poor man's report, so it should be taken in as a supporting evidence in whatever the case may be. So poor acute guidance, it is better as a trend marker rather than a point of care tool. Presepsin rises early than procalcitonin, potentially more infection specific issues are there, and detects subclinical AKI early. NGAL helps in the balance between fluids as well as in driving out nephrotoxins, but the limitation is that it is not specific. Thank you very much.